This is a 52-year-old male with right distal and radius fracture, and he's posted for ORIF. Dr. Sandeep Diwan sir will be demonstrating the infraclavicular block for this patient.
इसके बाद यूआई एमटा दिखा के अपर लिम्ब दिखा दूंगा सारा, फिर लोअर लिम्ब तो फेमोरल नर्व्स है। तुम यहाँ पर दिखा।
Devesh, am I audible?
Yes, sir, you are audible.
So this is the infraclavicular block. We go with the neurostimulation technique first. This is the clavicle. I'm palpating the coracoid process. This is the coracoid process. And 2 centimeters medial and inferior to the coracoid process would be probably, if you insert a needle at this point, it goes through the pec major, pec minor, 2 pops. It usually lands on the lateral cord. We expect a biceps response. We try to fine tune it to get the posterior cord or the middle cord response. Now, if you palpate the C6 tubercle, the midpoint of the clavicle and the axillary artery, they usually lie in one line, and this is called as the brachial line of Paulo Grossi. And this needle insertion, it lies exactly on this point. So you have the subclavian artery, which will be palpable here, and you have the needle point for the subclavian perivascular. This is for the interscalene, this is for the infraclavicular, and then that would be for the axillary. So these are the anatomical landmarks. So ideally, we should get posterior cord response, a middle cord response also would suffice. And let's see if we can do it with neurostimulation. If not, then I would just insert the needle under ultrasound in real time and advance it just posterior to the artery and inject local anesthetic that would spread in a donut fashion posterior to the artery, lateral and medial to the artery. So just preparing 50 gauge, 50. The sterlium, please. So paint and drape. So we use chlorhexidine. In the past, we used to use iodine, Savalon, iodine, and spirit. Then it turned out to be betadine, and now it's just this sterlium. So a lot of changes in practice patterns as well. If there is anything new, you can ask Dr. Devesh. No. So small amount of local here at this point. So again, palpating the coracoid process and then going 2 centimeters medial and inferior to the coracoid process. Skin subacute. Needle 50. Yeah. So we have to flush it with saline or local anesthetic. That should not matter much. Some they don't dislike using local anesthetic because they say that it won't lead to any evoked motor responses. Evoked motor responses are the muscle contractions after you neurostimulate. So we should not have the sensi mode. So you come off the sensi mode and we'll have at just 1 milliampere. So always mention this to the awake patient, small prick, even if you have injected local anesthetic. Remember, these are blunt needles, so you have to be superficial, so go tangential, just the skin and the subacute first, and then make this needle more vertical, and then advance it. So I already had a pop here, but we do not get any contractions. So I will just try to. So this you could say the local contractions And that could be probably the lateral cord with some movement of the in the supination, but that's not we are aiming for. Can you increase the current? No, there has to be some change in this. So this is the pec. This is right in the pec plane, because here you can see the contractions of the pectoralis major. So this is in the intropectoral. So we don't require, we have to advance the needle. You have to lose those contractions. So just redirecting in cephalad or the caudal, then a bit more medial. So just trying to reassess the coracoid process, go 2 centimeters medial and inferior. We are right in the plane, but you usually get the contractions in the pectoral region, which we are avoiding. He's a thin patient, so not more than 3 centimeters to 4 centimeters below the skin, the needle insertions. You have to be careful again with that as well. Not in the sensing mode, no? No. So sometimes it can be very, even in the thin patient, you find it a bit more difficult. So then we apply the probe and just inject posterior to the artery. That's more easy. So for the last time, 2 centimeters medial and inferior, somewhere in this area. You could get the contractions of the lateral cord, but we are not getting contractions of the posterior cord, which is the classical extension at the metacarpophalangeal joint. Okay, so we use the probe now. Yes, Jalil, please. That's okay. This is fine. So we can also understand what usually went wrong here. Depth, padao, please. Increase the depth. So this is again a sonocyte, and you can see the artery very well placed. We can see the cord, which is the lateral cord. The posterior cord may not be visible, but I intend to place my needle. So can we increase the depth a bit? Yes. Yeah, but that's all. That's fine. Okay. Can you remove that yellow color? So this would be the needle entry. It's going in between the medial and the posterior cord. You can see just skirting the artery there. Try to see the needle positioning, the tip of the needle, very important in all this. Yeah. So you're getting the response here. Camera dikhao. Yeah. So if it is visible, yeah, can you increase the current a bit just to demonstrate them? Yeah. So that's the medial cord. So I'm going to inject my local here at this point, a small aspiration and a small injection of local. You can see the medial cord there. So this is hardly around 4 ml, which would suffice. Now the challenge is to go towards the the posterior cord as well. I'm going to go a bit more caudal here, but it's going away from the artery, so there's no point. So I would withdraw this needle and then angle it a bit more vertical. And try to assess the needle tip. So a small pop here, and so you have to be careful that it's not in the artery. You can see the lateral cord, you can see the stimulation of the brachioradialis and the biceps. Can you inject, please? Yeah. So it goes periarterial. You can see that it's lifting the sheath over the artery, and it's going lifted the sheath over the. Wait 1 minute. I'm just going to pierce this sheath which is covering the lateral cord. Yeah, can you inject? Yes. So that would cover the lateral cord. Can you now increase the depth? You have to give 4 ml. 4 ml is enough. So 4 ml at each of these sides. I'm going to go a bit more angulated. You can see it's almost at right angle, and the posterior cord was not reachable. So that's again the response to the lateral cord. That's the musculocutaneous stimulation. I'm going to go beyond this, keeping the needle tip always in view. Depth badao, please. Depth, yeah. And the very fact that it's rightly sitting on the serratus anterior, that's the reason why you could not get the posterior cord very easily with the neurostimulation. Yeah, aspirate, inject a very small volume. You can see now how the artery is getting cleaved away. It's getting separated from the posterior cord. So the posterior cord was lying hidden here, and it was lying just behind the artery. Yeah, 2 more ml. You can also see the sheath which is covering, that's the posterolateral sheath. I'm going to now penetrate that. Yes, inject please. Yeah, inject. You can see the entire artery now being lifted from the posterior cord. So now it lies well between the posterior cord and the artery. This is where you have to target your needle insertion, exactly posterior to the artery. But we had very small space, so I'm just going to go still more, a bit more in, advancing the tip. Yeah, inject please. Yeah, you can see how it's getting cleaved away from the artery, the sheath. Yeah, thank you so much. So this is the infraclavicular. We could not get it with neurostimulation because the middle cord was between the artery and the vein, which is very clearly visualized. And also the lateral cord, there was a steep angulation. So the challenges faced again is a steep angulation. And the needle was in between the lateral cord and the artery, advancing the tip towards the posterior cord. The posterior cord was compressed between the serratus anterior and the posterior aspect of the axillary artery, and that's why this could not be reached in this occasion. So this is just around 16 ml of local we have given. So I usually use around 12 to 15 ml for an infraclavicular block in such kind of thin patients. Now we'll just shift the probe from the I've got the 2 machines here. Can show the machines. So this was the Sonosite ZX which was used, and now this is the Logic E that I'll just try to demonstrate the spread of the local with this machine. If you can just shift that, you can unfreeze this. Yes. So I'm just going to swipe my probe. This is the medial aspect where we can see the rib and the pleura, and you can see the serratus anterior very well placed. Can you use the volume?
Can we decrease the gain, sir? The gain is too much for us to visualize.
Gain has to be reduced now?
Yeah, this is appropriate. This is the appropriate gain.
Okay, so now we can, yes, can start.
So this is what Dr. Divan is doing, a panoramic view.
No, no,
of the
Devesh,
cost-
this is not the panoramic view. Panoramic view will show. This is a different view. This is a 3D mode where you can see the volume spread of the local anesthetic in all the planes. Like what Satyajit is now demonstrating, he's trying to show the spread. You can see the spread over the artery. You can see almost the spread. It's spreading all along the below the pectoralis minor and the lateral cord, and the posterior. यहाँ पे नीचे. हाँ. Yeah. So that is the entire spread, Divyesh, what you can see as a 3D. You can rotate this image. So if you can rotate rotate हो सकता है क्या? Yes. You can also rotate this image and demonstrate how in a cubical way the spread of the drug is. So this is a 3D spread which is demonstrated by this linear probe. So this is a linear probe which was used. Normally they have got
the drug spread tracking from the infraclavicular space to the costoclavicular space?
No, this is not. This is just in one plane, Devesh. This is not in the multiple planes. This is demonstrated in one plane. We'll try to show it in other planes. So that is the plane which is above and which is very close to the costoclavicular. Now, we need to imagine a lot, Devesh, in this case. We have to be tuned to this. Okay, now coming to the panoramic view, just the last one, the panoramic view.
So we would like to see the drug spread from the infraclavicular space to the costoclavicular, whichever probe you are comfortable with.
Okay, so this is the now the infraclavicular spread. I am now going to make this probe from the parasagittal. I am going to make it in the costoclavicular, and then trying to see the spread into the costoclavicular space. So you can see the space here. It's hardly any volume of local except over the lateral cord maybe. Can see that spread around the lateral cord? It can see, yes, that's the spread. The posterior and medial, they don't have any spread. I'm coming more caudally now. And caudally you can see the spread now here with the, again with the same coronal oblique in the infraclavicular. You can see the spread in the infraclavicular area between the artery and the vein. Can you see that spread between the artery and the vein?
Yeah.
And you can see in the posterior cord as well. So I think, Devesh, more of it has gone more caudally. If you see this, I am going to make it more longitudinal. See, this is the artery. I am making it longitudinal. So this is the artery, and these are the cords.
Yes, on
So-
top of it we can see.
Yes, now we can see the two cords there. You can see the two cords, the three cords in fact. All the three you can see. I'm going towards the axilla. So I think more of spread towards the axilla than spread more cephalad. That's the artery. So I'm going right in the axilla. You can see more spread caudally than the spread in the ऐसा panoramic. Yeah. Be like this. So let's have a look at this spread now. Yeah, start please.
So this is the panoramic view.
Yeah, that's the panoramic
where
view.
doc-
Where you can see the entire pectoralis major, the minor. You can see the cords, both the cords. You can see the lateral cord and the medial cord, but you cannot. I'm not able to delineate the posterior cord here, but you can very well see those cords in the panoramic view. Yeah, back to Devesh. We commit the second block immediately. We can have questions later on if you want.
Okay.
Same, except the needle.
Maybe second block.